Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Gustavo Lucar Lopez from Barcelona, Spain. Dr. Lopez is an orthopedic surgeon specializing in foot and ankle surgery for over a decade. He completes undergraduate studies at the University de Carabobo and he completed his orthopedic surgery residency at the Hospital de Mataró in Barcelona, Spain. He has authored numerous research papers and contributed to advancements in foot and ankle surgery. Dr. Lucar Lopez has also been an active member of professional organizations such as the European Foot and Ankle Society and the Spanish Society for Foot and Ankle Surgery. If you've noticed, Dr. Gustavo has lectured in our channel in the past and it's already reached a huge audience. And today is my great honor to bring back Dr. Gustavo Lucar Lopez for this wonderful live program. Over to you, Gustavo.
Hello, everyone. Thank you for being here, and thank you for coming to share knowledge with us. Thank you, Dr. Gopalan, for the invitation. I'm more than happy to come. And if I came twice, that means we have a good thing in common. So today I'm going to talk to you about something that may be familiar or not to you, which is the TTT or the TBT, which is the new approach or assessment to the revascularization in the diabetic foot. So as Dr. Gopalan explained, we are in the university hospital, which is Mataró University Hospital. The foot and ankle unit is conformed by three of us, Dr. Manuel Ballester, Dr. Alaiz Bello, and myself. And as you see, we have three generations of surgeons, around 50, around 40, around 30, and the three of us combine the private and the public hospitalization, surgery, recon, and trauma cases. So when we think about diabetic foot and we think about the treatment, the first thing that should come to us is basically the multidisciplinary assessment of the diabetic foot. It's important to be centered in one person that leads the way, that may be, depending on the hospital and the setup, a podiatrist, an orthopedic, an expert nurse in diabetic foot. And important to have basically all the branches of this multidisciplinary equipped, meaning we need a nurse to gather the team, we need an endocrinology to have a correct medical control. We need a podiatry if we can afford it, basically because they can give us a small approach for surgical small techniques. The orthopedic will give the hint of mechanical issues and the orthoplastic assessment in the diabetic foot. The vascular is super important, key piece in this area, because they will give us the blood supply, they will give us the blood to carry on the antibiotics, to carry on the limb salvage. And we also need infection diseases expert and plastic if we have the possibility. So when we have a diabetic foot and we have a ischemic foot, that's basically the worst of two cases, because as we know, the diabetic foot has a epidemiology with very challenging trouble regarding ischemic issues, because you have the vascular disease or the vasculopathy meeting the neuropathy, and you can have ulcers, you can have risk of amputation, you can have open wound with or without pain, and that's basically when you have the infection also, you have the worst case scenario ever. So that means we need more than one brain thinking about it and giving different approaches. When we do the multidisciplinary assessment, we need to think always in our vascular surgeons. We have a team of vascular surgeons with advanced techniques to avoid amputation and to preserve the irrigation and as long limb as possible, and they do either open or close surgeries. And basically, the thing about this kind of patient is that they have long occlusions, they have all the microvascularization which is damaged, and the residual vessels are not too many. We have a disease of the whole vascular system, and many of these cases are not suitable for an open or bypass or endovascular recovery. So if you add to this problem a mechanical alteration and a neuropathy, then we know we are in trouble. And the easy way to avoid having this patient is basically to amputate. But the amputation is not a thing that is a good thing to the patient in many cases, because you can have a mortality rate that could be around 30-40% in a year. It can come up to 60% a year. You have a loss of mobility and a functional dependence. That's a big social issue for the patient, because it will cause trouble for the patient. It will cause a social problem to the family. It will be a problem that will at least touch 2, 3, or 4 people in the surrounding of this patient. So that means the patient cannot work. The family member, one of them maybe, cannot work, so they have to help this patient. So the social cost for society is very important. Don't even talk about psychological issues and all that, because you have an amputated limb. So the idea is, before throwing the towel, think about newer and more salvage procedures. So in this case, we are going to talk about the transverse bone transport, or TBT, or TTT also called, which is basically a distraction osteogenesis. And what is this? What does this TBT or TTT means? It basically is super new. It's from the 50s. So basically, it came directly from the Elizarov studies. They did from the 50s all this distraction osteogenesis. It wasn't meant to do this or to be this way, but basically what they found is, when you do an osteotomy, when you have a traction of the bone, this start forming an angiogenesis and an osteogenesis, and creating new vessels in this gap of distraction, not only in the osteotomy area, but in distant areas. So these biological principles are basically due to the separation of the cortex of the bone, which leads to a hematoma with the apparition of new vessels, and this biological approach that will lead to new small branches in the distal part, and the recovery of the correct irrigation of the distal limb. This was many years ago, but then around the 2000, the Chinese start studying this with longer periods, with more patients, with different indications, and they started publishing this. So it start sounding, for the Occidental world, start sounding like something that is coming, and at least promising. They treated in diabetic foot, in ischemic foot, in critical ischemia, and in some cases, problem such as osteomyelitis with low blood perfusion. So basically, the idea and the final goal is to do this surgery that you see on the left in order to achieve this angiogenesis that you show on the right. Basically, do a mechanical treatment in order to develop a biological response. So coming a little closer to our date, basically what is seen in these cases, if we have a significant increase in the microvascular flow, that can be seen in the Doppler or the angiography, a reduction in major amputation, and we are talking in severe diabetic foot, which are not suitable for a surgery. If we look closer for what happens inside, basically we have an elevation of angiogenic growth factors. These growth factors are basically the seeds that we need in the limb to start regrowing vessels, and improvement in the transcutaneous oxygen pressure, and that can help in ulcer healing. So this surgical technique is probably simple for all of you. I will follow through one of the current techniques that are made for doing this bone transport. This is a cadaver surgery. So basically, we go to the proximal medial part of the shin. We can use a model to create a big flap. This big flap needs to be big because it needs to close, and we need to open and close this layer in order to do the cortical osteotomy. It can also be done percutaneously, but for initial cases, I would probably recommend this type of osteotomy. So we do 3/4 of the osteotomy, and then we leave the last cut for the finish. We do 2 pinning of what will be the inner part of the fixator. Then you cover with the flap, leaving this image right there to the right. And from that point, we take out this ruler, we put the pins, and we fix the rest of the fixator. This should be the image that we have in the X-rays. Important, the most inner pins will be in the loose fragment, and the outer will be in the fixed fragment, in order to have a special device that will take this cortical out and in. This will be our postoperative image. If I need to be super critic, I would probably do the flap a little more more eccentric to the central pins. But this is a good image. And this is a case. This is a 73-year-old patient with a very bad ischemia of the limb, with also this osteomyelitis and an open ulcer. We did the TBT procedures and a debridement of the area. And this is 3 weeks from the surgery. If you see, the most important thing is not to have a closed wound. The most important thing is to see the color of the foot, to see how these foots go from a pale pink to a red foot. And it's very interesting because you see the wounds are getting a lot better. The X-rays are looking very good. As you see in the left image, you can see the cortex outside in most separate moment. And then you see even these small distal ulcers, how they regrow from this point without touching them, without doing any debridement. And this is the magical part about this procedure. This is the same patient 1 year ago, 1 year later from the first procedure. We did the same thing. We step a little later because he already came with this big necrotic infected ulcer, and we wanted to go again and see what happens. So in this case, we are more accurate with the flap. We respect the skin a little more. You see this is another device from another brand, and this is the final image. And you will say, well, you have an amputated foot. That means you have a more expensive surgery than you should have. But it's not that. You have a patient that was on transtibial surgery to be done, that can walk with a footwear, with a correct adaptation, who is not dependent for the rest of the family members, who can climb stairs, and If you have a correct patient, that will walk normally or very much normally. So that's probably the interesting thing about this kind of procedure, because the difference between supracondylar amputation, a transtibial amputation, and a foot amputation is very big regarding on the problems with the patients. This surgery can have some trouble. Basically, the more important part is to have a flap, which is very you need to take care of this flap very much. You have to have a big flap. It's important. It's better to have a big incision and a well-covered flap than this, because this was some of the initial cases, and you can have this image. But then in this case, what we did is we did a Friedrich, and we did a bigger flap to close once the osteotomy was done. When should we consider this surgery? Basically, we could consider this surgery in critical lower limb ischemia with or without infection, when we know we have a peripheral advanced arterial disease, only when the vascular surgeons cannot take care of it by doing an open surgery or by doing endoscopic surgery with a procedure or a bypass. So basically, these are the patients that they rule out for one reason or the other, and we need to have a limb with a better irrigation. So in summary, the indication for this kind of surgery would be advanced ischemic foot. You can talk about classification, but in general would be advanced ischemic foot, chronic limb ischemia, ulcers that are not healing, either they are infected or not. Of course, if they are infected, we need to do a correct debridement and antibiotic care. When you have an osteomyelitis combined with a poor perfusion, because you will do a debridement as normal, you would do a carry of the antibiotics by doing this procedure, and it will help the regrowth of and the wound healing. When you have a refractory ischemic pain that we haven't done yet, but there is in the list of possibilities, so I explained it there. And if we want to use it as a help of other procedures, such as external fixator or a reconstruction case. When we are not going to do or don't think about this surgery, basically if we have a deep active infection that is giving trouble to the patient, if the patient is septic, if the patient is not stable, it's not a good surgery, because it will do a second hit to the patients. If you have a very bad necrosis, because the necrosis won't grow back, it's important. If you have a severe cardiac or renal failure, it's also not a great idea, because you are going to do a complex procedure and you will have a longer recovery, and you need to have a proper patient. And the uncontrolled diabetes, basically you need to have the best situation in a bad patient to have good outcomes. So the last thing I want to invite all of you, if you want to come to beautiful Barcelona in November, we are going to perform an advanced diabetic foot reconstruction course here in Barcelona in our facilities, and we will talk and do this kind of procedures also, and the rest of the orthoplastic treatments. If you want, just write us an email. And lastly, I give you some information here, or for where do we start in TBT, TTT cases. But nowadays, if you check online, you will have many cases from around the globe. Thank you so much, and I hope you like this discussion.
Thank you, Gustavo. Yeah, thank you, Gustavo, for this wonderful presentation. And it's kind of cutting edge. I would like to let you know that our last presentation on endoscopic FHL transfer has been, I mean, a lot of people have started watching our presentation, and congratulations, Gustavo, for that.
Thank you so much. It's important to do things that can cause an impact. Either it's a local impact or a global impact. For us, it's a privilege
truly.
to have these possibilities to reach into to doctors worldwide, and you have our mail there. So anything you can that we can help you, just write us down. And otherwise, Dr. Gopalan also have our contact.
And so we're getting back to our main topic: transverse bone transport, right? Transverse bone transport, TBT.
Yeah.
Gustavo, I just want to know about the specific surgical technique. See, you have a unique device there, and is it a staged transport, transverse transport, or it is an acute transport?
Basically, as any commercial brand, they want to develop their own. Basically, the idea is to have 4 pins, 2 in a fixed position, 2 in the cortical area, and from the moment you cut, you start doing traction around 21 days, and then you have the cortical going all the way to the initial site. Basically, you have 2 kind of devices that I know, basically 3. One is the open one. It's probably for initial cases, it's a good idea, I think, because it's easier to understand the procedure. The other one is basically you can do it percutaneous, which is, if you have a very good hand by doing percutaneous surgery, the soft tissue envelope is more controlled. You have less trouble doing aggression to this side. And I even have friends in Mexico and Latin America who start doing it manually using a small hand wrist distractor. And what they do is they start millimeter a day going back and forth in order to do it in a way which is basically affordable to third world or to a places where they don't have the capacity or the economy or these 2-3 brands that are developing these devices. So that means you don't need to have the exact brand to do this procedure because as Elizabeth explained and the Chinese explained, basically this is a biological response caused by a separation of the cortex. So we don't need to be super accurate. I think it's important to gain advantage of the brands and these people that want to give us these procedures, but don't forget the basis. And the basis is basically biologics, which is cortex out and in, and that's it.
Okay, so for 21 days, you're going to take the cortex off, and another few more days to bring the cortex in. How many days?
It depends on the specific protocol of brands. For us, would be surgery day 1, maybe 1 week of rest. From that point, 1 millimeter day, that would be 2 centimeters of distance. And from the day you finish that, going back until you touch the cortex. In early weight bearing, basically we don't stop moving around because we want this foot to have the more activity possible. And the control, if it's the only surgery you're doing, the wound cover and everything is it's not very complex because it's all very in a part which is not problematic. The patient normally will have a good sensation about this. And we do basically every week we check out the skin and the rest, which is going okay. If you have a debridement, you do a normal, correct debridement as you would do in any other situation. And we are start thinking about doing it in more complex reconstructions, such as charcoal, super construction, etc.
And it's basically a rectangular piece of bone that
Yep.
goes off the anteromedial tibial cortex. Am I right?
Correct. Yeah. Yeah.
And what would be the approximate length of this rectangular piece of bone?
It's around 8 to 10 centimeters. I don't recall exactly how much, but as you
Approximate. Okay.
as you do in this square, that's a correct square.
Okay, great, Gustavo. And Gustavo, I just want you, I mean, you said one of the contraindications would be a critical limb ischemia, right?
Right.
And a critical limb ischemia, according to the ABPI, ankle brachial pressure index, would be around 0.4 and less.
Yeah.
So you always do in addition to the ABPI, you always do a Doppler, right?
Yeah, normally these patients come to us referred by the vascular surgeon, and basically they will they know the indications, and basically it's a patient that in theory they should operate, but for one or other reason they cannot do, like patients that are suitable for endovascular surgery, but they have too compressed or too technical complexity for doing the endovascular, or because they're maybe a little older for big bypasses surgery, or because they cannot control the infection. So these cases are salvage procedure. They talk to us. We see if they're suited for surgery, and we do. It's not super common because normally we have a very strong vascular team, and whenever they can, they will lead the surgery. But in these cases that they want to throw the towel or think about doing this amputation, they contact us and we say, don't amputate, let's do it. And then we do the follow-up together. And we want to start putting levels on changes in the index of the transcutaneous oxygen and the pulses and all that, but still in development. In the States, I think they are talking more accurate about that, but we don't have that many cases, so we're gathering information for the moment.
And Gustavo, the literature that you mentioned, even I was checking at the literature, most of them are data from Asian, like Chinese papers. And I just saw just one systematic review by Lyndon Mason. I mean, I've hosted Lyndon many times on our channel, and he has a systematic review in foot and ankle, and which says that, okay, so the Western literature is yet to catch up with this particular technique. Agree or not?
Yeah, I would if you see where does it come? It comes from communist country to communist country.
Okay,
and
so
then,
even Spain, you have Pedro Sanchez with a slight communist ideology. Am I right?
well, depends on who you ask. But I will probably say the Occident war were reluctant of doing it because I think maybe it's a little controversial, but we sometimes have a little bias of who explains what, and we want to perform it more or less. And if a guy from the States tells one thing and it sounds good, it's probably easier for us to try it. And that's probably not the greatest things. We need to check information prior checking which country it comes from. It's easy to check correct methodology. Either it comes from Egypt, the States, China, or Africa, or whatever. So I think we need to be very critical of what we read. And the Chinese, I think they have a big advantage. They have many patients, many big population, and that probably help them develop these numbers, which are unreachable for us because we are a 40 million 40 million population in Spain. But in Spain, we're probably in the middle with Western and Occidental. So we're a little open-minded. And in Spain, probably around 10 people that I know are doing this. So I think it's growing stronger little by little. You need to do a correct patient selection. You need to have a very strict patient. You need to do a lot of steps. It's not for everyone. It's not complex. The surgery is not complex. The indication and the follow-up is more complex.
Yeah, I think we need to have, see, there's a systematic review that's been published, but I think we need to have a level 1 RCT, right? To say actually, okay, TBT is actually superior compared to some other treatment methods. For example, your endovascular techniques like using a balloon or whatever. Do you agree that we need to have a level 1 data?
Yeah, I would probably say for the moment, whenever you could do an endovascular procedure, do it. When you need to throw the towel for technical or patient complexity, you can have a long talk to the patient and the family and explain this as a possibility. It's important to talk to the patient and to talk to the family.
Thank you, Gustavo. Gustavo, I think that's all the questions that we have for this session. Thank you for yet another brilliant talk. And I'm sure more and more people are going to start using TBT. And I'll give you an update in the upcoming months regarding this presentation. Thank you so much. Bye-bye.
Bye-bye.
Pleasure.